She has over 20 years experience in health information management. And during this time, she's worked with the Alabama Quality Assurance Foundation and Florida Medical Quality Assurance. She's past president of the Alabama Health Information Management Association, distinguished member of AAHIM for 2003, and served on the CSA task force for HEMA. She's worked with several consulting firms and also owns her own. And we're very fortunate to have her presenting for us this afternoon. So Joy, thank you for being here. Before I hand it over to Joy, I want to review a few housekeeping rules to make sure we have a successful webinar. First, all attendees are in listen-only mode, which means you'll need to use your control panel to communicate. You can find your control panel on the right-hand side of your screen. If you need to minimize the panel so that you can see your screen better, you can collapse and expand it by clicking on the little red box with the arrow. If you want to ask a question, you can do that in the questions section of the control panel, which is towards the bottom. To ask a question, just click on the plus button to open up a text box, and you can type your question in the box. At the end of the webinar, we will try to answer as many questions as we can, but please note that if we run out of time, we will pass along any outstanding questions to Joy, and we'll follow up with you by email after the webinar. So please feel free to ask whatever questions you may have. I also want to point out that handouts for today's presentation can be accessed from the handout section of the control panel if you'd like to use those as a reference. And finally, most importantly, CEUs. Tomorrow morning, we'll be sending out an email to all webinar attendees with a link to a brief webinar evaluation. Please complete this evaluation, and then once you submit your response, you'll have a link to download your CEU certificate. If you have any questions or you don't receive that email, please feel free to send me an email. That's cbyron@trucode.com, and I'll make sure you get your certificate. All right, so thanks everybody for joining, and with that, I'm going to hand it over to Joy.
Thank you, Sharon, and good afternoon, everyone. We appreciate you joining this afternoon, and hopefully the things that I have to share will be of value and interest to you. I do not intend to obviously cover all of the changes that went into effect October 1 with ICD-10-CM. I'm going to really focus in on some study of the first year's data with coding with ICD-10 and some of the errors and issues that they found, and then along with that kind of walk through some of the areas where there were a lot of questions and confusion and errors, and some coding clinics that came out at the end of 2016 and this first quarter of 2017 to kind of address some of those issues. This first slide here kind of shows you what they found when looking at productivity issues, the impact of ICD-10-CM coding on productivity. And 30 to 45% productivity decrease was what they found kind of in general for inpatient records. I've kind of done a little poll or a survey for various clients to find out how true that is to what they're experiencing. Some of them found about that, some found more decrease, some found less. I think obviously a good part of that decrease is going to have to do with how many inpatient procedures your facility does, because obviously PCS coding definitely slows down productivity. 20 to 40% productivity decrease on outpatient records, which is a little interesting to me too, and I don't know if that has anything to do with perhaps sometimes the outpatient coders are not as versed in specificity issues as the inpatient coders, and perhaps the increased specificity with ICD-10 had an impact. I'm not really sure about that. Obviously an increase in quality reviews, because people do want to make sure that the coders are doing this correctly and making that transition from I9 to I10 as accurately as possible. Obviously not unexpected to have a decrease in coder accuracy, and we're going to have to wait over time to see how that looks. Obviously looking at second year data will be interesting to compare back to the first year's data. That next bullet is kind of interesting too, because they didn't find a real clear correlation between productivity and accuracy. A lot of possible reasons for that, but just sort of an interesting finding. And then the last one, proportion of unspecified codes staying constant over time rather than decreasing, because I think you would expect that as people got more familiar with ICD-10 coding that they would the specificity would get better. Again, I think some reasons for that. One of those is, of course, that a lot of that is dependent on whether the physician documentation is getting better. And I'm sure you, along with myself, are finding that just documentation in general in the EMR is getting less rather than better in many cases, because the physicians are using so many shortcut avenues through the EMR that they're not always really documenting as clearly as they once did. The other thing that might play a role in that as well is that a lot of people are still trying to just focus on specificity for certain codes that drive the MSDRG assignment and that kind of thing. So we'll have to kind of watch that one as well. So one of the things that I wanted to start off with, one of the things that they kind of found in this process is it's a pitfall to be so dependent on the encoder. We really need to understand the coding process and how the alpha index and the tabular function and all the instructions that come with that. So many of the changes that we experienced in this last update, October 1, related to index instructions such as the diabetes with guideline and the hypertension with guideline, etc. And if you don't see that information, if you don't look at that information in a code book or in an encoder that allows you to see that, that can have a big cause a big problem with accuracy. Also, if a coder sort of thinks that they know how to code a certain thing and they develop a bad pattern, it becomes a repetitive thing that repeats itself through time, and so it really makes that error rate look even higher. Another couple of things that are kind of problems in some of the encoders, they group some things together, like in this first bullet here, the place of occurrence and the activity codes. The 3M decision tree requires those in a sense for all injuries, and those are not appropriately assigned for all injuries. Some of those codes are only assigned on the very first time that the patient comes in for the injury, and if they come in for subsequent care, then those do not apply. Place of occurrence guideline also kind of some of the encoders ask that you assign that Y92.9, but there is a coding guideline that basically says do not use that code if the place is not stated in the documentation. And the same thing with the activity code guideline. Do not assign that Y93.9 if the activity is not stated, because those really don't give you any helpful information. Another thing that's kind of built into being too dependent on the encoder is the unspecified versus uncomplicated issue for certain code categories. In particular, they found an error in those codes that relate to alcohol and drug-related conditions and disorders, where coders were often selecting an unspecified code when really the documentation and the record and what they really should have chosen was an uncomplicated issue rather than an unspecified condition when there was no associated condition existing. And then CEUs, some of the encoders are directing the coder to the sepsis codes, and that is not how you code CEUs in ICD-10-CM, and so we will be talking about that a little bit more in detail in just a few minutes. Also, search engines. We're having to look up a lot more clinical information and a lot more information on anatomy and physiology and all of those things, trying to code with ICD-10-CM and PCS. And it's very important also, some coders go out there and actually use the internet to find codes to kind of help their productivity, but you must always make sure that you check that against the tabular code book to make sure that the instructions and everything that's there really do apply to the case that you're trying to code. And also, when you are trying to look up information on the internet about a procedure or a clinical diagnosis, Wikipedia is not the most reliable source. You really need to develop for your coders a list of reputable sites for accessing information, like the National Institute of Health website has a lot of helpful stuff. The Merck Manual site has a lot of helpful stuff that's much more reliable clinical information and procedural information. And it's really helpful if you can, within your facilities, develop a list of sites that coders know that they can go to and get accurate information. So going into the common coding errors that were found in year one of the things that kept frequently showing up in the data was the use of R65.2, which is the severe sepsis code, being sequenced as the principal diagnosis instead of the code for the underlying systemic infection. And obviously that is not following the correct sequencing guidelines for ICD-10. Or sometimes they also found if it was sepsis related to a complication of care issue, that they were either assigning an incorrect and in many cases a less specific complication code, like this example here of the T80.219A, which is an unspecified infection due to a CVL, versus T80.211A, which is a bloodstream infection due to CVL. That happens to be actually one of the PSI indicators, the patient safety indicator. So it's important that that information be translated into the most specific code possible. Also, they just found in general that the code assigned by the coder did not really match the condition that was documented by provider, and I guess perhaps some of that is just a lack of clinical knowledge or pathophysiology knowledge. And then obviously the 7th characters for episodes of care continue to cause problems. It's unfortunate that they decided to use that initial word in the 7th character rather than active treatment. So you have to really think about what type of treatment they are receiving for an injury or a poisoning rather than which visit, because initial is a misnomer. Active treatment is what you should be using for that initial visit character, and anything that is subsequent treatment would go to the other 7th characters that are available. Another interesting one is nicotine dependence. There are a lot of different ways that physicians document this in the encoder, and they're being coded a variety of ways. A lot of people also are coding just sort of a generic nicotine dependence when it's clear in the record that the patient is using cigarettes, and so you need to get the most specific code possible. And just kind of a little sidebar about that particular issue, I think it's really important to capture smoking or either current or history of smoking because it affects so many different healthcare chronic conditions, but I find so many conflicting pieces of documentation about that, where different physicians will pull from the problem list, and some will document the fact that they're not smoking any longer as never having smoked, where other parts in the record say they quit 5 years ago or they quit 2 years ago or whatever. So there's just a lot of real conflicting information out there in that particular realm. Another area that's caused some problems is coding that B95 to B97 infectious agent category for conditions that are classified elsewhere. An example, of course, would be like a UTI, where you're going to have the N39 code, and then you need to add that B96 code, for example, if it's an E. coli infection, to show the causative organism. People are getting that use of that confused with the A00 through B94 category, where you have a combination code where the actual condition and the infectious organism are rolled together. So those are very distinct ways of coding something, and you need to make sure that you're using both of those groups correctly. The B95.B97, as I said, is for when the disease code that you are coding does not include the infectious organism, and you need to add that as a subsequent code to show the infectious organism, such as the UTI I just spoke of. Also, one thing that kept showing up in particular was that B34.8 viral infection unspecified site coded incorrectly, rather than the B97 viral agents as the cause of diseases classified elsewhere, which includes codes for the specific type of virus. Influenza A, a lot of errors with influenza A, and I was just doing an audit recently that had this same issue. The doctors will document influenza A, and you'll see the positive test on the record. But there's a lot of confusion about there. There's a coding guideline that you see on the slide here that influenza due to certain identified influenza viruses can either be coded to J09 or J10. And the provider documentation of influenza A must state avian influenza or other novel influenza A in order for it to be classified to category J09. Those are fairly rare. You don't see those very often. And so when the physician just says influenza A, that is not going to be assigned to that J09 category. That's the equivalent of H1N1 or H3N2. The doctor has not identified it as novel or variant influenza, so that would be assigned to that J10 category. Some of the non-specific diagnoses that they found showing up a lot at the top of the list is the diabetes without complications, but because of the interpretation, if you will, or clarification of the diabetes with in the alpha index, we should not really see a whole lot of those unspecified diabetes codes being used anymore, like the E11.9, because there are not really that many things that are possible complications of diabetes that are not included under that with list. And one of the things that I'll just point out while we're talking about this, as we move down the road with severity reimbursement, that those diabetes with complication codes have a huge impact both in the APR-DRG system and in coding for HCCs that affect some other types of documentation and reimbursement. They have a huge impact on the severity scores of patients and encounters. So it's really important that those diabetes with complication codes be picked up whenever possible. COPD is another one of those that we don't always see the specificity needed for acute exacerbation, for example. CHF, again, that's probably the top query out there in the country, is the type of CHF. That continues to be an issue. Breast cancer, they certainly would like, more site-specific information on breast cancer and prostate cancer, and also sometimes just really making sure that you clearly understand whether something is still being actively treated and coded to the cancer code, or whether you're coding history of cancer because the treatment is discontinued or completed. Hypertensive heart disease, obviously the big shock of all of us for October 1 was now assuming that automatic link between hypertension and heart disease that we have never done before with ICD-9. So that should start taking care of itself as well with that reinterpretation of that guideline. And then angina and rheumatoid arthritis. Some other things that frequently get missed, and these are significant because they do affect severity in APR-DRGs and with HCCs and other things. And again, we need to focus more and more on not just what affects an MS-DRG payment, but what affects the severity ranking for these patients, because that's going to have such an increasing impact on our reimbursement going forward. So artificial openings, status post-amputations, having a AAA, aortic atherosclerosis, and probably one of the issues that I have a pet peeve about this is doctors documenting peripheral vascular disease or peripheral arterial disease, and that's just kind of a non-specific generic code rather than actually specifying that it is atherosclerosis of any kind of vessel, whether it's the aorta or another vessel. And that's something that we're going to need to work more on with specificity. Pathological fractures of the vertebrae sometimes get missed, late effects of CVA, chronic DVT, major depression, and then alcohol and drug dependence. Some of the other root causes of coding errors, sometimes the diagnosis description in the physician's documentation is, it's hard to translate that to the description of the code that we have in ICD-10-CM, especially with some of the major changes in specificity and the way things are classified in ICD-10-CM. Vague or different diagnostic criteria, and as you know, sepsis is just such a big issue because we basically kind of got three sort of sets of criteria to work with out there. We have the criteria that have been in the coding guidelines for quite a long time. We have the sort of the Sepsis 2, or the criteria that came out of the Surviving Sepsis campaign. And now we have the new Sepsis 3 definition, which is hugely different, and we're going to talk about that a little bit more later in the presentation as well. Also, we have different categories or criteria for acute kidney injury and malnutrition, and again, those are causing some issues with coders trying to figure out, how to apply criteria and assign codes based on the documentation from the physician. Obviously, the complexity of the terminology and specificity I've already talked about. And then, within ICD-10, there are sort of multiple or redundant ways sometimes to code a condition, and trying to figure out what is really the accurate way to translate what I have documented in this record into an ICD-10 code. Another issue is with POA, present on admission errors. They're finding, post-op conditions with a YPOA, which obviously isn't correct usually. Electrolyte imbalances that develop after admission being reported with a YPOA, a UTI with a positive urine culture on admission that is reported with an N, post-op hypothyroidism, status post-thyroid surgery prior to admission reported as an N, thrombocytopenia with low platelets present on admission reported as an N, ischemic cardiomyopathy reported as an N. I mean, that's a long-term chronic condition, and it doesn't develop within one episode of care, so obviously that's not correct. Probably the number one reason why this is happening is because coders get in the habit of just marking Y on everything, and they don't pay real close attention to when things develop. Another thing that's not on this list, but that I'll mention as well, is the guideline, sort of the revised guideline that came out October 1 about POA indicators for combination codes where they have multiple clinical concepts. Both of those have to be present on admission in order for you to use the YPOA. So, for example, I looked at a record the other day where the patient was a long-term COPD patient with chronic respiratory failure, but they came in and developed acute respiratory failure after admission, and that was assigned as a POA of Y, when in fact the acute phase of that did not develop until later in the stay. So now let's get into some more specific types of conditions and guidelines that we want to make sure we're aware of. We have the new codes and the new guideline that went into effect for diabetes with oral hypoglycemics. And it states that the use of insulin and oral hypoglycemics is important to capture if the documentation in the record does not indicate the type of diabetes but does indicate that the patient uses insulin. You're going to assign it a default to type 2, E11, and then you're going to add the Z79.4 or the Z79.84 assigned. This has sends a big message to people out there looking at the data about how well that diabetes is being controlled, and so it's real important to capture those, and in particular the Z79.4, which we were already doing because that has a lot to do with severity ranking, but the Z79.84 is important as well. The question is what if a patient is on both insulin and oral hypoglycemic drugs? I'm going to address that again in a minute when I go into the guideline on diabetes and pregnancy that came out for 2017. And then the coding guideline for hypertension that, as I said, is kind of new to us, where it basically is now saying that the classification is going to presume a causal relationship between hypertension and heart involvement, which is something that we had never done prior to October 1. We've always done that with hypertension and kidney disease, but not with heart involvement because it does fall in the alpha index of hypertension with. So it says these conditions should be coded as related even in the absence of provider documentation explicitly linking them unless the documentation clearly states the condition is unrelated in some way. Another guideline that was sort of reinterpreted for us is evolving pressure ulcers. If a patient comes in with a pressure ulcer that evolves into another stage during the admission, we now are supposed to assign 2 separate codes for that, one code for the site and stage on admission, and then a second code for that same site and the higher stage that it progressed to during that stay. CEUs coding, I mentioned that a few minutes ago with the encoder dependence issue. Coding Clinic 3rd quarter 14 came out and said that patients that are diagnosed with CEUs secondary to pneumonia are only going to be assigned to the initial infection, in this case the pneumonia. When sepsis is not present, no other code is required. ICD-10-CM does not have a separate code for CEUs due to an infectious process. This is different than how we coded it in ICD-9. So be aware of that fact. If the patient does appear to meet criteria for sepsis and the physician is still using the term CEUs, then certainly a query would need to be issued because often they are using those terms interchangeably, but they are not interchangeable in terms of how we code in ICD-10-CM. Also be aware of the fact that even though you can't code CEUs due to an infectious process in ICD-10-CM, you can code CEUs due to a non-infectious process such as pancreatitis. And this is another question that came up about CEUs and diverticulitis. Is this the same type of a situation as CEUs due to pancreatitis? Is that considered a non-infectious process? And after looking into a lot of information about this, we have concluded that based on the definition of non-infectious in the dictionary, which says not spread by contact, inhalation, etc., not able to spread the disease, that diverticulitis would be considered a non-infectious disease because the bacteria is coming from within the intestine and cannot be spread to anyone else. So we would consider that diverticulitis, SIRS due to diverticulitis, would be coded as SIRS due to a non-infectious process. And you can see that Merck manual link there if you want to take a look at that further. The Sepsis 3 definition I mentioned a few minutes ago has just caused all kinds of issues. The new definition says a life-threatening organ dysfunction caused by a dysregulated host infection, or response to infection rather. Septic shock is now defined as a subset of sepsis with circulatory and cellular or metabolic dysfunction associated with a high risk of mortality. Basically, when you read through all the information out there about Sepsis 3, it seems to now be defining sepsis as what we typically have in the past coded to severe sepsis, because there basically has to be some type of organ dysfunction clearly indicated and linked there to even code it as sepsis under the Sepsis 3 definition. And so that means that for a lot of the cases that are out there that we would typically code to sepsis with no organ dysfunction, that we might end up ultimately, once that Sepsis 3 definition really is fully embraced, only coding to the localized infection the way that we're currently doing SIRS due to pneumonia, for example. So we got a lot of work to do in this area of trying to clarify all of this for coders and CDI people and physicians. Basically, as you are probably aware, they came out in third quarter 16 stating that coders should not assign a code for sepsis based on clinical definition or criteria or clinical signs alone. It is based on the physician documentation regardless of the criteria or definition used by the physician. And our coding guidelines in terms of querying the physician are to be based on the classification as it exists today. So we would continue to code sepsis, severe sepsis, and septic shock per the most current classification and guidelines that we have now. But because of these other sort of conflicting definitions and the way the payers are looking at this, that leaves us with a lot of MD education and querying to try to make sense of all of that. Also, they came out with some examples about how to code viral sepsis in third quarter 16. Here's one about viral sepsis that says assign A4 1.89. There is no code for viral sepsis in ICD-10, so this is the best option available. And because that doesn't really specify the organism, then you would need to add that additional B97.89 to show that it is a viral agent that's causing that sepsis. And you would not, of course, assign the severe sepsis code unless there was an associated acute organ dysfunction with that viral sepsis. Same thing, sepsis due to a viral syndrome. This is coded a little bit differently than the other slide, however. In addition to the A4 1.89, instead of using the B97.89 that I mentioned previously, in this particular case, you would code it to B34.9 because when you look in the alpha index, syndrome, the word syndrome sends it to that B34 code instead of the B97.89 code. COPD with pneumonia, this was something that people were kind of haggling about all last year, and they did come out with a coding clinic third quarter of 16 that gave a lot of examples. But basically, if you have COPD with an acute lower respiratory infection, and per the National Institutes of Health, that includes bronchitis, pneumonia, and bronchiolitis. In that case, the COPD code needs to be sequenced first. If you have a patient that has COPD exacerbation as well, and the pneumonia, you would need to do the J44.0 plus the J44.1 plus the J18.9. And it really doesn't matter whether the J44.0 or 0.1 is sequenced first because both of those COPD codes will go to the same DRG. So then that raised the question about what about COPD with aspiration pneumonia? And again, first quarter coding clinic that just came out that goes into effect with, I think, March 13th discharges, does state that aspiration pneumonia is a separate kind of pneumonia. It does not fall within the respiratory system chapter. It's coded to that J60 to J70 category. So if you have a patient that is admitted with COPD and aspiration pneumonia, that J44.0 instruction does not apply. Both of those would be coded out separately, and the sequencing, of course, is going to depend on the circumstances of the admission and the focus of the treatment. It also went on to say in that same coding clinic, and that should say first quarter 17 there instead of 27. I apologize for that typo. The same thing would apply with COPD and vent-associated pneumonia, because again, it doesn't fall within that respiratory system category. Postop anemia is another one that people have struggled with in the past. Fourth quarter 07 stated that if the physician did not state acute blood loss, it should be coded to 285.9, and the AHA coding handbook said the same thing. However, when you look at how both I-9 and I-10 are indexed, and you see here post-op, due to, and acute is in parentheses there, and it does send you to that D62. Those parentheses are considered the non-essential modifiers, meaning they may or may not be present. So the D62 would be the correct code in that particular case. Also, we had some issues with the way that ICD-10 defaults for primary osteoarthritis. And as you can see here, if you have osteoarthritis of the shoulder, hips, those both default to either the M19 or the M16 category, which takes you to a primary osteoarthritis code, and that's something that you want because then you're able to get the site-specific codes that go with that. Whereas osteoarthritis of the knee, for whatever reason, does not default to primary osteoarthritis, but to an unspecified code. So we have these coding clinic references that came out in fourth quarter 16 that do state, first of all, that it is okay to assign the primary osteo of the shoulders and hips, but it is also okay to do that for the knee, to code it to that M17 category rather than going to the default code that the index takes you to. Default for arthritis, as I just said, defaults to M19.90, but you do not want to code it that way, and they go on to state that arthritis is primarily meant to represent osteoarthritis in the United States, and so they try to set up the defaults just to reflect that. Not sure why the knee didn't get set up that way, the way that the other two did, but primary osteo is the most common form that we see. It's age-related, caused by wear and tear on the joints. Secondary osteo has much more specific underlying causes such as injury, obesity, genetics, etc. Also, the substance use codes that are out there, there's been confusion through the year about how those were used, if the patient was just taking drugs correctly, or if they were using something recreationally, and the physician documented that in the chart. So they came out with this guideline that basically says that those use codes should only be coded for based on provider documentation, and only when the psychoactive substance is associated with a mental or behavioral disorder documented by the physician and linked back to the drug or alcohol use. For withdrawal, it's not likely that you would even code that to drug use. Obviously, that would be dependence. And for any of the situations on this slide, if it's unclear, you would need to query the physician. Hypertension, diabetes, and CKD. So we have, some interesting things to consider with this. Second quarter 16 talked about diabetes and associated conditions and advised us to use that, assume that link, diabetes with, unless the documentation clearly stated that the conditions were unrelated and due to something else other than the diabetes. In the same token, there was a guideline for fiscal year 2017 about hypertensive CKD that also goes on to state that CKD should not be coded as hypertensive if the physician specifically documents a different cause. So, if the physician says diabetes and hypertensive CKD, should you also assume the link with the diabetes and the CKD in that particular situation? The answer would be no. In that particular case, the physician is specifically specifying that the CKD is due to hypertension, and so in that case you would code the diabetes unrelated and then the hypertensive CKD. And this is reverse would be true, that if they called it diabetic CKD and hypertension, where the physician has clearly identified that the diabetes is the underlying cause of the CKD, then you would code that to diabetic CKD and not also to hypertensive CKD. If, however, what you get, which is typically what I see, is hypertension, diabetes, and CKD, all documented with no links identified, you would code both hypertensive CKD and diabetic CKD. You would assume a link with both of those underlying conditions. The hypertensive heart disease guideline that came out caused a lot of angst because the tabular under I-11 says includes any condition in I-5 1.4 through I-5 1.9, and it does not include that I-50 code there. However, there is a use additional code note to identify the type of heart failure listed there in the tabular. And then the guidelines that came out for October 1 also specifically said that it does include that I-50 code. Obviously, they just left that out inadvertently, it would appear, and they came out in first quarter 17 again to reiterate that that I-11 category does include both I-50 and the more specific heart failure codes that has been referred to the Coordination and Maintenance Committee to try to get that I-50 added into that code range in the tabular. Also, they came out with a coding clinic first quarter 16 to supersede advice that had come out in first quarter 14, where it told coders that they could not specify these types of HF, PEF, and REF into the types of heart failure, but they are now saying that you are able to do that. So if the doctor documents heart failure, preserved ejection fraction, you can translate that into diastolic heart failure, and if they document heart failure, reduced ejection fraction, you can translate that into systolic heart failure. Another issue is readmissions post MI, because we have that new definition of 4 weeks or less. If a patient comes in 3 weeks post MI for some other thing like COPD exacerbation and chronic bronchitis, you still need to add that I-21 code in there if you have clear documentation that the patient has had an MI within the 3-week or 4-week time frame, rather than coding it to the history of MI. And that can have a huge impact on severity scores and ranking as well. Lewy body dementia, they had some issues with the excludes one note under that FO2 category that said you could not use that with the G3183. And so they came out in fourth quarter 16 and they have deleted that so that it's not conflicting anymore. So if you have a diagnosis of Lewy body dementia, you are going to use the two codes, the G31 code and the F02 code together. Diabetic cataracts, back in the old I-9 days, they talked about how diabetic cataracts were rare, and very rarely did you actually see them as a diabetic complication. They have now revised that guideline, and cataract is one of those things under the diabetes with and the index, so those are now being considered an automatic related or linked condition. They also came out with, again, some reiteration about coding from a path report. Again, under I-9, we were told we could not code from a path report, so they've now come out and said in third quarter 16 that if you're talking about inpatient cases and there's conflicting information, that you are supposed to query that. They talked about if a patient is admitted with a brain mass and then the path report comes back with astrocytoma or some specific type of tumor, it is not okay for the coder to automatically code it to that astrocytoma without querying the physician. Pressure injuries, you can't look up pressure injury in the alpha index for ICD-10. In April of 2016, the pressure ulcer advisory panel changed the terminology from pressure ulcer to pressure injury and updated all the stages. So Coding Clinic has come out in third quarter 16 and said, this is not a definition change, it's a terminology change, so that if you have documentation of pressure injury, you are going to code that to pressure ulcer, and the stages that we use for pressure ulcers do correspond to the pressure injury stages that they developed, and so you can make that translation. And again, a reminder that a deep tissue injury is coded as an unstageable pressure ulcer. Encephalopathy due to diabetic hypoglycemia, again, some problems with that. They had come out in third quarter 15 with some advice on this particular issue. where encephalopathy hypoglycemic was directed just to code to the hypoglycemia. They did clarify all of that, and now they're telling us that you would need both codes, the E11.649 and the G93.41, to code type 2 diabetes with hypoglycemia and metabolic encephalopathy. And then the WITH guideline that I've been sort of talking about all along, it is important to pay attention to that guideline and presume those causal relationships between conditions, with some caveats that I'm going to talk about in a minute. Diabetes is the one in particular that we have been reminded of, and as I said earlier, picking up those complications under that diabetes WITH are important, and just about everything you can think of that's a possible complication of diabetes is listed under that WITH, including the addition of osteomyelitis for October 1. So it's important that you assume that link unless the documentation delinks or specifies another condition. However, I heard someone ask the question in the AHIMA coding meeting this past fall about whether you could assume that in every situation within the index where WITH shows up. And when you start working your way through that, it gets a little bit sticky. I've already talked about this, so I'm not going to go into that anymore. Here are all the things that are under diabetes. But what about this? If you look up diverticulitis, diverticulosis, and gastritis in the index, those both have a WITH bleeding underneath them, which is presumed to be a link without the physician documenting that bleeding and linking it back. And that's, of course, been an issue forever, because when the doctor comes in and does an EGD and a colonoscopy and they're not bleeding on the table, they'll never link it back to anything. And the coding, AHA coding handbook for 2017 still says the combination codes describing a hemorrhage should not be assigned unless a physician identifies a causal relationship. So until we get some further ruling from coding clinic, you have to decide what you think is reasonable about this. And some of the consultants and I that work together and consult on this have some issues with assuming a link if they go in and do an EGD and colonoscopy and they find several things that could cause that bleeding. So my personal opinion is if you have only one GI diagnosis on your record, I don't really have a big problem with assuming that link to the bleeding. But if they find 2 or 3 things, or if the patient is on anticoagulation therapy as well, I have a problem with automatically assuming links to all of those things, or assuming that the GI problem is the issue and not anticoagulation without a physician query. But that's something that you're going to have to make some decisions and policies about so that your coders are consistent. Another issue that's a problem is sepsis with organ dysfunction. Again, technically you should assign an automatic link there, and one of the latest CDI handbooks does advise that. But the sepsis guideline for I-10 still states that the acute organ dysfunction must be associated with the sepsis in order to assign the severe sepsis code. So I personally, again, feel that if it's not clearly linked by the physician and you really can't tell, I'm probably going to query the provider instead of assuming links there. Then the bugaboo, so to speak, is the clinical validation versus coding issue that came out in that 27 guideline number 19. The reason this even happened is because there are a lot of payers that are denying things for lack of clinical validation, Humana in particular, and some of the RACs that are now starting up full force again are doing that as well. And so in many cases it was being considered a coding error for the coders to code something that they came back and denied based on medical necessity. So coders in some cases just didn't code that. And so basically what they're saying is that we have to code based on provider documentation. It's not up to us to decide that just because we don't see the clinical criteria met that patient doesn't have that diagnosis. You can also see the fourth quarter 16 coding clinic, and there's a revised practice brief that came out on this as well. The clinical documentation or validation issue does talk about how CMS feels that clinical validation is most appropriately performed by CDI professionals or other people that have more advanced clinical background than just, the coding professionals. Definitely getting physician advisors and CDI people involved in the process where you have one that you're not sure it meets is very important. And that last bullet there, I wanted to just emphasize that if a payer or clinical validation reviewer disagrees with the diagnosis, that should not be considered a coding error. It is a clinical validation issue, but it should not ever be considered a coding error because coders are instructed to code the diagnoses that the physician documents in the chart. Going on back to the 2013 practice brief, it did not really give advice on how to determine if a diagnosis was supported by clinical indicators. The updated 2016 version did talk about the fact that even though Coding Clinic has clinical indicators in certain cases for sepsis and respiratory failure and things like that, it is not considered an authoritative source for establishing clinical indicators for a given diagnosis, and it was not intended for that purpose. Clinical indicators should be taken from the specific record under review. Clinical indicators supporting the query can include and should include elements from the entire record, such as diagnostic findings, provider impressions, etc. But the reality of our world is that the payers are still denying things based on clinical validation. And on this slide, I have shown you the top ones that Humana is denying, and in Blue Cross and Blue Shield in some states, in particular sepsis and acute respiratory failure. So we still have to figure out, how we're going to deal with that. So they came out with some information on this escalation process. Again, talked about in 2013 practice brief, updated in 2016. It does state in the 2016 update that a query is appropriate when the documentation provides a diagnosis without underlying clinical validation. It is advised that a query be generated to the attending physician to address that conflict, and or that it be sent up through the escalation process. You're going to have to develop some internal guidelines to determine which diagnoses are most vulnerable, and of course the ones that are most vulnerable currently are on this next little bullet here. So initially the attending would be queried for some clarification. If the physician did not respond within an appropriate time or within an appropriate response, then it needs to be escalated up to a CDI physician advisor, which hopefully you have one, and if you don't have one, then own up to the chief of the department or the chief of staff. One thing that I just want to say, in closing, it's almost time to wrap it up here, but I work with a lot of hospitals that really don't have physician advisors, and they don't have a lot of physician input into their CDI process. And also, I'll say that when you get a denial back from Humana or the RAC or whatever, usually, even if it's not in the first letter, in the second letter, if you rebut it and it comes back, they will usually state the criteria that they are using. It's really important that you get information from the payer about A, what criteria are you using? We need to know. And B, do you have physician review in your built into your process? And you need to take a look at those criteria, because what you'll find sometimes is that the criteria is being misread, misquoted, misinterpreted, which is important why you need to get the source of the criteria and actually look at it yourself. And the other part of that is that it's really critical when you try to rebut something like that, because they are dealing with criteria that are clinically driven. You've got to get some physician eyes into that process. So if you don't have physician advisors that you're working with, it's really important for you to try to figure out, somebody on your medical staff that can take a look at that record from a clinical perspective and come up with a rationale for why they feel that that patient clinically has that condition, even if it doesn't technically meet the, quote, criteria that the payer is using to deny or downgrade that DRG. And the only other thing that I wanted to just say as well The first quarter 17 coding clinic just came out. As I said, it goes into effect or went into effect with March 13 discharges. If you have not taken the time to take a look at that, you need to, because it has a lot of things in it that have are changing, that are important based on questions that people have submitted through the past year. So you need to make sure that you look at that very carefully. And one of those in particular that I just happened to notice when I was looking at it was one related to uncontrolled diabetes, because with the new changes that came out in October 1, it now tells us that we have to specify uncontrolled, meaning hyperglycemia or hypoglycemia. It's not enough for the physician just to say uncontrolled or poorly controlled in order for us to automatically, quote, determine that it's going to be hyperglycemia. You really have to have documentation to support which way that goes. But as I said, it's important for you to take a look at these coding clinics, because I expect that the next ones that come out, and I expect also the update for October 1 of this year, are going to be as massive as what we got last year, because there are just still so many questions and things that are coming to light as people are coding with ICD-10-CM that we need clarified. So please do whatever you have to make sure you stay on top of that, because if you do not stay on top of that, you will not be able to code accurately. And it's just, you know, it's quite a job to stay on top of it, but it's extremely important. And Sharon, I'm going to turn it back over to you, because I am finished with what I can say.
All right, thank you very much, Joy. We do have a couple questions that maybe we can cover as many as we can, and then with the time we have left, and then the rest we can follow up by email, if that's okay, Joy?
Sure.
Okay. One question we got: if diagnoses are included in progress notes but not in the final discharge summary, and treatment was provided, can the coder go ahead and code those conditions?
Absolutely. The coding guidelines do clearly state that the entire medical record should be used as a basis for coding, and there, unfortunately, especially with the EMR, there are a lot of cases where the discharge summary does not include a lot of those things. I also find sometimes that by the time the doctor does the discharge summary, he focuses on the last part of the stay instead of what presented at the beginning of the stay, which is what drives the principal diagnosis. So definitely, if you see information, you know, documented by a provider, a legitimate provider in the progress notes or consulting notes or whatever that is a diagnosis and treatment, you definitely need to pick all of that up.
Okay, thank you. Next one is pertaining to substance abuse and recreational drug use in the ER setting. Do we code if the patient admits use to the nurse, or only if the physician documents it or diagnoses it?
Well, again, I'm so inpatient oriented that I don't know if that substance use guideline I talked about earlier applies in this case. Typically, you do need, just in general, you do need to have physician documentation of a diagnosis to pick that up. But my question about the ER setting is whether there also has to be documentation of an associated disorder with that to even pick it up at all. And unfortunately, I would have to do some research on that in the ER setting to be able to fully answer that question.
Okay. Should you code both long-term insulin use and long-term oral hypoglycemia use?
Oh yeah, I was going to talk about that, and I forgot to talk about that. I thought I had a slide in here, but I have a little bit of a question about this. And you know, when you look at the guidelines for diabetes with insulin or oral hypoglycemics, I'm sorry, it kind of says use the code for insulin or oral hypoglycemics, okay? And then when you look at the pregnancy guideline that came out, where it talked about if they're on both, that you would just code the insulin use only and not code both. In other words, you would default to the most severe type of control, which is the insulin use. I kind of feel like that should apply across the board to all diabetic patients. I haven't actually researched to find out if there would be any reason why you would do it differently for a pregnancy patient than for a diabetic patient. But to me, once you know that they've had to progress to insulin control, I'm not sure that it's helpful to have also the oral hypoglycemic in there Again, that's kind of my opinion. And because there's a little bit of a conflict or more information in the pregnancy guideline than the regular guideline, I've got to pursue that myself a little bit to find out, if we can use the same rule for non-pregnancy patients, that if they're on both, that you would just assign to Z79.4.
Okay, thank you. Maybe we can keep going, see how much time we have left. Let's see. We have a lot of IV heroin abuse in our area. That is all that is documented. I'm never sure how to code this. Is this a poisoning?
Yeah, well, it's going to be coded to dependence, obviously, I believe. But again, I'd prefer to answer that, like not off the top of my head, like submit that and let me really research that and make sure I give you a full answer to that question, if it's okay.
Sure. Thank you. Okay, this question might be related to a previous question. What if the physician does not document the final findings from the path report? Can the coder code from the path report or have to query the physician for same-day surgery procedures?
You cannot code from the path report. Well, are we talking inpatient or outpatient?
Doesn't
if you're talking an inpatient, you cannot code from the path report. And a lot of times what happens is the path report comes out after the patient's discharge or the date of discharge, so the doctor doesn't have the documentation in the record. And that guideline I went over does say that you cannot code from that path report. You do have to query the doctor to get that additional pathological finding documented before it can be picked up.
Okay. Okay. Let's see. Maybe we can do what? Get to one more.
Okay.
Pneumonia is not defined as a lower respiratory infection in our tabular, J20 to J22. It is defined in the influenza and pneumonia block. How can coding clinic override the tabular in this classification?
I'm not sure what you're referring to when you say that.
Okay, so maybe
I probably need to have them submit that with a little bit more detail so I can take a look at what they're saying. But in general, the tabular is not defining pneumonia as a lower respiratory infection. The National Institute of Health is defining pneumonia as a lower respiratory infection. So I'm not sure if you're talking about, because this code range doesn't fall within, I need clarification about what you're really asking for that.
Okay, so if that person wants to submit a follow-up to that question, we'll pass it on to Joy. And yes, Joy will, for the questions that are submitted, Joy will respond, and then I will follow up with you to make sure you guys get the information you're looking for. But that brings us to 3 o'clock. So for the questions that I didn't get to and the questions that Joy's going to look into, we'll certainly be in touch on those. I want to thank everybody for attending today. Thank you, Joy, for an awesome presentation. And again, just remember, look for an email tomorrow morning. That email will have a link to the evaluation, and once you complete that evaluation, you will be able to print out your CEU certificate. Any questions, email me, cbyron@trucode.com. Thanks, everyone.
Thank you.